Добрый день.
Good afternoon, dear colleagues. Good afternoon, dear friends. In the first place, I would like to welcome everybody here, and I would like to welcome those who are near their PCs. And I would like to say that myself and my co-chairs, my dear colleagues, at our session, Tsyganova Elena, uh, chief expert for HIV in the Central region and deputy chief infectious doctor, head of the scientific clinical department of Moscow AIDS Center, Department of Health of Moscow, and also represented from Kyrgyzstan. Your name and patronymic, please. I fear I may not just pronounce that properly. Nuria Burdushanovna de Kyrgyzstan. Thank you. Then we are just starting our session. Well, I will just introduce myself. And Mikhail, head of laboratory of viral hepatitis of the Research Institute of Vaccines and Serums, named after I.Mechnikov. I will speak about the actual of diagnostic treatment prevention of viral hepatitis in Russia, and we will present some of the new information, and in this limited time we will speak about 5 major types of hepatitis and the results that we have. In the first place, I should say we all know that viral hepatitis are the typical situations when we see only the cap of the iceberg. So this is only acute condition, and the biggest number of people in Russia, 6 million, with chronic hepatitis B and C, and the viral hepatitis, they have a descending trend. In 2020, we had the record low numbers for the whole history of records, and there was a role of COVID in all of that. Let us start from hepatitis A. Well, the problem of hepatitis A is still relevant. All of the hepatitis are relevant for the planet and for Russia. And it is very important here that, like for other hepatitis, we have a decrease in incidence in almost all regions of the country. And the spread of hepatitis R, they have still seasonality and also variations in the country. And mainly it is typical for children's population, 1.5 in Russia as an average, and there are regions, and there are 6 regions where the incidence is higher compared to all Russia, and in Bryansk region, so as 116.33 among children. So that was the prevalence, and of course here I would like to present our experience. So when we used into one-time vaccination of children, we vaccinated over 40,000 children at the age from 2 till 16, and this one-time vaccination dramatically decreased incidence. And before that, the incidence was 242 and 7.7 in this age group. and there are no cases of acute hepatitis R in the Republic recently. And it is interesting to analyze the post-vaccination antibodies, and if after the first injection, 1 month after the first injection of anti-hepatitis vaccine, and that was a high number, 98%, then in 5 years time it is around 91%, which is quite a high level, and that's not clear why the titers of antibodies increased after 5 years. We should study this, and we are following the situation. One dosage of the vaccine for children decreases incidence not only among children but among adults as well. That could be used in other regions with high incidence of hepatitis and hepatitis E. So I would like to speak about that. It was discovered 40 years ago by Mr. Bulayanov. So this is the hepatitis with outbreaks in the south, in Uzbekistan and Tajikistan. For a long time it was believed that Russia and the countries with moderate climates, they do not have this problem, and there were fundamental studies according to which hepatitis E, its source are animals, in particular mainly these are pigs, and the interest is very high both in Europe and our country. In our country we have a low incidence, less than 100 last year, and in Germany up to 50,000 people with acute hepatitis E. And another interesting thing which changes our opinion about that infection, there are neurological manifestations, non-liver ones, non-hepatic ones, and chronic cases of hepatitis E, which was not typical for hepatitis A, and there are lots of questions here. I would like to present the first case of chronic hepatitis E in Russia in a young person with Beckett's lymphoma. And in 2020 he had RNA of hepatitis E, and the enzymes were high, and with the RNA, so in fecals and in blood serum, you may see it here, and he had the chronic hepatitis. We treated him with ribavirin 800 milligrams per day orally, and the result was quite good, and the RNA of hepatitis E was both in fecals, and then in January we just did not find it anywhere, and now in the world there are up to 6 mutations of RNA of hepatitis E virus which are resistant to ribavirin, and we analyzed, we did the complete genomic sequencing, and when we looked at the first serums in August 2020, we found only 2 mutations related to ribavirin resistance, and there was a gradual increase in number of the mutations, and
несколько мутаций, 4 из 7.
There were 6 out of 7 mutations that we found him. Despite that, ribavirin treatment was very important. I think when you work with chronic hepatitis of unclear origin, we should take into account that that could be hepatitis E, and despite such mutations, you can have a positive result. And of course, we are going to watch him for more time, but for now the results are good. And hepatitis B. And hepatitis B, it's one of the most mysterious hepatitis. It seems like we know everything about that hepatitis, but still there are no secure ways to get rid of integrated hepatitis DNA, and there are cases of hepatitis B transmission ongoing. And the main factors which helps to fight against hepatitis B is the presence of vaccine, its availability. In Russia, we had the program called Health, and many people were vaccinated. In 2019, there was a total of 10 million people vaccinated against hepatitis B, but unfortunately, in 2020, the vaccination rate against hepatitis B went down, which is sad, and we should pay special attention to that, so that the pandemic doesn't have any impact on hepatitis B, because the consequences of hepatitis B are very unpleasant. And one more thing I would like to draw attention to, one of the factors to fight against hepatitis B is vaccination of the newborns, and we need to vaccinate in the first 24 hours, and up to 1 year there should be more than 90% of children vaccinated. These are 3 times vaccinations. The analysis is done before 1 year of age. If we see that in this period the percentage of vaccination is high, from 90 to 99%, the second dosage is used not always. In this period, children are less protected from hepatitis B compared to timely vaccination. We must do that. Another question which has been discussed for coronavirus as well, and the examples of hepatitis B are given on the mutant variants of hepatitis B, which can not be protected by the traditional vaccines. And here we make an analysis of the most pandemic regions, and in Republic of Sakha we did not find the number of mutant forms in this region. The next hepatitis related to hepatitis B, it's hepatitis D without B. Delta or D cannot exist. It is very important to watch out for this type of hepatitis in hyperendemic regions. We work in Tuva and in Sakha, and this is interesting that dynamic follow-up for the people who have the antibodies to delta antigen. In Sakha Republic, the frequency of D incidence decreased, and in Tuva it's at a high level. It's around 38-39% among HBS, and we find these RNAs and DNAs. I really like that slide. Here you can see that the incidence of delta in children and adults of the age of 20-29, and thanks to vaccination, that because hepatitis B vaccination is also eliminating hepatitis D. And then the timeline is very interesting. After phylogenetic analysis, after making such trees with the time scales in Tiva, hepatitis B was for 2000 years, and delta is a new infection. It came there only 60 years ago, and there is a chance that hepatitis D may enter other republics. One of the hotspots in our country is Dagestan, with the wide spread of delta infection. And also hepatitis C, we all know how serious it is, but the results that we have and receive with the help of new drugs, so the give wonderful, surprising results and give our efficacy about 98% from treatment. And today we are going to have the presentation by Dr. Chulanov about the progress on elimination of hepatitis C, and we focus on these 2% that do not respond to treatment. And here the incidence and the range of important polymorphism in resistance-associated substitution RAS, and also the goal was to assess the factors promoting its spread. It is well known that there is association of mutations R70QH in core protein of hepatitis C, and it is associated with 1B type, and over half of virus C infected, they have this genotype, and the spread of this mutation in Russia is about 30%. It means that there is a big share of patients with this subtype of hepatitis C. They are prone to high risk of developing primary hepatic cancer. And we found out that some of the widely spread in Russian population molecules of HL1, for example A02 or B07, they can link the core proteins of 1B hepatitis if they contain the variants R70 and L91, but not the replacements, 70Q. And introduction of screening to analyze those important factors, it's important, and detection of mutation may be important for the next steps in treatment. At this stage of analysis of mutations related to drug resistance and 1B and 3A patients, the important mutations in these patients amount to 5.4%, which is not more than in other countries of the world, though there were high incidence of mutations M28V, about 60%, but among the genetic isolates of type A, and with lots of types of resistances to different drugs of direct action. So this is just only small information. We are very thankful to the organizers for the invitation. I hope that we are going to further advance in that. I would like to thank all of the authors, Dr. Perigyan, Dr. Semenenko, Dr. Malinikova, and other employees. I would like to thank employees from the regions of the country who participated in this work, and I would like to thank you for your attention. Thank you so much. Thank you for listening. Thank you for exciting presentation. The next presentation will be online. Mikhail, I'm very happy to see you and listen to your wonderful presentation and about the hepatitis C. I would like just to learn your experience. The idea to use chemotherapy in our country to create the special program. It's just this idea is in the air. And also we have a recent article and authors from Novosibirsk, they just suggest to do that. What about chemotherapy for HIV and hepatitis? So yes. Yes, this idea appeared some 4 years ago. It's in WHO, and there was the European plan established and designed, so where there were lots of different suggestions together with the academician Yushikov. We published a suggestion to do that for all of the hepatitises. But now we have wonderful opportunities. I know that these works are ongoing. Dr. Chulanov will speak about that. I think we must do that. We are obliged to do that. If we want our future generations to be healthy, we need to do that together with the chemotherapy. And we may use the medicines approved in our country, and there is a big room for discussion, the use of generics, and they are flooding our country, and how they are helping people. The question that you ask, it's of high importance, and no doubt we would like to do that. On the other hand, I am concerned that the coronavirus pandemic is an impediment, and there are global examples, successful examples in Georgia on its treatments. But we should now focus and do the studies, all of ours together, to be successful. This is my short answer to your question. May I just announce the next presentation? And that's a great pleasure for me to do so. Why? Because it is presented by my friends. So these are the researchers. This is Timur Haililuin. This is a person well known in the world. I am very happy to see you in the screen. Well, that's sad. We cannot. Erkin Isakovich, please. And you have the floor. Can you hear me? Professor Musabaev. So, thank you for such a warm welcome. I am not to blame for that. Moscow, Istanbul. So the flights were cancelled starting from April 15, and the whole of our delegation could not come. And that would be a great pleasure to meet in person and talk. This is a bit of too ambitious of a name. The contradiction paradigm of diagnostic treatment of chronic hepatitis B. What was done by Thomas Kuhn, the paradigms, as he wrote, I mean all of the scientific achievements which give the models and criteria. So this term is widely used, and we have some examples which includes the lore and the theory and the equipment that gives us the models which give rise to traditions of scientific trials. As for viral hepatitis B, the main paradigm are those wonderful studies performed by Taiwan researchers. And 15 years ago, you understand that in the 90s, the quantitative assessment for hepatitis B appeared in the 90s, and with their persistence, they tested and studied over 3,000 patients for many years, and this is the well-known study. In line with that paradigm, everything is related to the viral load. If the viral load is high, as you may see, almost 14%, 15%, in 16 years. Erkin, so sorry, you just do not have the presentation, it's not changing. I'm terribly sorry. We can see you, but we cannot see the slides. Maybe somebody could help. Yes, we have here the IT guide now. Erkin, you know, when we had the Olympic Games, so there was Rodney and Zaitsev and the music stopped, and without music, they received the golden medals in the Olympic Games. I'm sure that you can do that without the slides perfectly. Sorry for such a technical delay. Well, it's not working. What can we do? So you may start your presentation. So I explained the first slide, the next one. Yes, we can see it. We can see it. I'm sorry. I already explained those studies from Taiwan, according to which it all depends on the viral load. This is the paradigm which remained unchanged for 16 years. And the same is applicable for cirrhosis risks, high the viral load in each third patient. The 16, 18, 15 years the cirrhosis is developing. And also there was a paradigm which shaped the treatment of chronic hepatitis B. If we look at the mutation, so these are the strategies of replication, viral replication. Only hepatitis C, as there is no nuclear introduction we can eliminate. For HIV we need to work on the replication, suppress it, and for B as the high um, load has an impact, and the low viral load had no impact. All of the national, international, American guidelines and studies, they were about that. And we are not discovering anything new when we developed the national protocol in Uzbekistan, when we have to use antivirals and when not. There were 2,000 copies of international units, and of course, if there are some factors related to family history or cirrhosis, these 2,000 copies should be looked at and the ART would be prescribed. But in fact, as you mentioned, Mikhail, in your excellent presentation, before my presentation, that the problems when hepatitis B is the following. The available drugs did not solve those problems because they have no impact on the DNAs inside the core, inside the nucleus. They impact on the pregenomic RNA replication, and in line with the paradigm which the as the research from Taiwan came up to, that was not bad. Let us decrease the load to get to some low level, so and everything will be fine. But all entecavir, ribavirin, they have no impact on the circular covalent closed DNAs, and this is the joint work with the Institute of Pasteur from St. Petersburg. We had 75 biopsies with end stage of liver diseases, and we checked the level of the ring DNAs. In red, unclear etiology. There is no DNA, there is no HBS, and half of those who have pre-cirrhosis or cirrhosis, in half of the cases, we would find the equivalent closed DNAs. So the etiology was found only in biopsies. We found these things. And the first contradiction against the paradigm, not everything can be solved with the viral load. If there is no viral load, if this is hidden hepatitis, it can lead to severe complications and end stage liver disease. The second paradigm, and the second contradiction, that all of the protocols ignore. In line with all of the protocols, I would like to just mention national, European, American. Every 3 months we need to check the viral load, but nobody identify how frequently it is changing and how frequently inactive hepatitis gets to inactive and vice versa. And there is no clear data how the viral load is changing for hepatitis B. And there is data on a reactivation of the process after immunosuppressive chemotherapy with autoimmune disease. In absence of those factors, it is believed that they can be, these things happen in 20 or 30% of the cases. And also, there are guidelines to do that every 2 or 3 months. But here there is economic details, and the ideologists analog, who is speaking practically at all Asian and European conferences. Well, I heard questions at 2 congresses. Do we have to test the viral load every 2 or 3 months because the price is less than one test, and the tenofovir has very minor side effects. The data on adverse effects of tenofovir you see for TTF, right? And especially after 6 months, so they're not different. And after 50 or 60 years of age, and they're taking statins, and the results from them may be much worse, though the statins are taken without any limitations. So the next contradiction, the paradigm. If we are treating those with high viral load, can it have an impact on epidemiological aspects? Will we be able to decrease the incidence in those who are not vaccinated? And what are the learnings from AIDS, working with the AIDS? Hepatitis B compared to HIV, it's much more contagious, a small dosage from an active phase sick person, so the viral load is going up. And also the high viral load is related to a horizontal and vertical transmission. So it means that we could not impact the incidence with our treatment scheme. What happened with HIV? Only when in Africa they tried to treat everybody irrespective of viral load, incidence started to decrease before there was an idea to treat everybody, not to look at the viral load. There was no major impact on the incidence. In fact, if we are treating everyone irrespective of independent of the viral load, like with HIV and AIDS, it will have a good impact on the incidence of the disease. The next aspect, treat all of the patients with a chronic HBV. There is a social, economic, and also scientific basis of that. So to do 15 years studies like in Taiwan, and of course this is difficult. Maybe somebody will start such studies, but there are studies which speak indirectly about the following fact. So early use of antiretrovirus may have impact on the incidence of complications. So these are the studies from Hong Kong. So this is the co-infected people. So HIV infection, the risk of hepatocellular carcinoma, and patients with hepatitis B. And you see what's interesting here. And in the group of mono-infection, these numbers were 5 times higher. And the researchers conclude that HIV and hepatitis have a low risk for hepatocarcinoma compared to people with mono-infection in the group with combined infection. So the incidence was lower. Maybe the severity was low because antiretroviral treatment for hepatitis B. So this treatment was started early and without assessment of the viral load. Tenofovir, other drugs, lemomedine is used. These medications, so they also have an impact on hepatitis B, though they are used for HIV. So the American researchers, there was a big cohort of patients with the co-infections, double infections. So they looked at randomization, all of the comorbidities. So this is the first table, and how many cases for monoinfection and how many cases for co-infections. So the 5 times less for co-infection. This is a paradox compared to monoinfection. So once again, we can make the same conclusion. HBV infected patient in the US, the frequency of hepatocarcinoma was for patients with HIV compared to monoinfections, and also the co-infection was associated with a decrease of long-term risk of hepatocarcinoma compared to monoinfection patients. It is proved by cohort studies, and we make the same conclusion. If HIV provides the early access to treatment, universal treatment for patients with infection can decrease the risk of hepatocellular carcinoma. And so this is the work of French researcher. This is economic analysis, which was offered by ESOL in 2020. So they analyzed cost efficacy of treatment with nucleosides. Now the price is $15 or even less. And treatment of all of the patients after diagnostics of hepatitis B is the most coefficient, and they were calculating the complications even for the low viral load, and they looked what would be the result, final result, like aspirin for people with the cardiac disease, anti ARTs. Now they just become like anticoagulants and statins. It is believed that we should treat everybody with that. And there is conclusion that early treatment provides for less consequences and side effects, hepatocellular carcinoma and liver disease, cirrhosis. So we should use more treatment at the early stages. And my colleagues will explain what we did in the pilot. So this is the extract from the pilot trial approved by our ethical committee, and 250,000 citizens of Tashkent were tested, and so you may get to active phase, and you may have cirrhosis and other complications. And in line with the national protocol, so the treatment is given for active phase patients, and we give it to antigen positive patients. Tenofovir, we use it for all of patients of HBs antigen. Well, that is probably it with me. The only thing about the change of paradigm. So this is scientific revolution, and we are not going to do any revolution, but That is the idea which is in the air, and gradually we get more and more supporters to change the protocols, the national and the international one, to treat all of the patients with chronic hepatitis B, irrespective of the viral load. And to conclude, I would like to thank the SDA Foundation, which allocated the budget, and despite the severe pandemic times in 2020, we had a big study, and we published it. I'd like to thank my Russian friends, the doctor of medicine, Mr. Simonov. He became the director of the Ekaterinburg Institute of Viral Infections. If he is listening to me, I would like to congratulate him, and my assistants and my helpers who were involved in the studies of DNA. Thank you for your attention. If you have any question, I think we have a second presentation.
Только большая просьба сделать его компактнее, потому что последний...
Just please be brief, just 10 minutes.
Потому что как бы общий блок он не займет больше времени, чем мы просили.
Здравствуйте, уважаемые коллеги.
Dear colleagues, good afternoon. For us, that's a great honor to speak about our pilot project on elimination of viral hepatitis in Uzbekistan, organized by CDA, US Foundation, Scientific Research Center of Virology, and Healthcare Ministry of Uzbekistan. The goal of this pilot was to demonstrate the efficacy of simplified recommendation on screening and treatment of chronic viral hepatitis, so that our country could launch that at the national level and to get to WHO goal to eliminate hepatitis by 2030. Here we may see the map of this project, and it's split into several stages. So the first stage is the invitation for a test for screening, then registration was online in the local clinics, and the patients would come to the reception. They would fill in the personal data. After registration, they would move to the next room for express test, and it would take 20 minutes. And also the positive patients, they were transferred to the procedure room for the next test. And we did express test for HCV, for HIV, HBS, and after that positive were referred for consultation. Patients for positive hepatitis C, we would sample blood for further confirmation of the diagnosis in the central lab. This is in the Scientific Institute of Virology. And we also test AST, thrombocytes, and creatinine level. Test results took 2 or 3 days, and then the patients would come back to see the doctor to get the consultation. Hepatitis B and C and blood sampling was done in the local clinics in Tashkent, and a total of 13 clinics participated in the program. 2 or 3 clinics worked at the same time. And every month there were 3 or 4 new clinics which joined all of the patients with positive HBC, HG, or anti-HCV. So they had a consultation with the nurse, which was previously trained. And in the first 3 months, the patients of UHAP were sent to Virology Scientific Institute, and also only patients with complications were sent to hepatologists, and then the doctors informed about the cost of ARTs, and it was accessible, sent them to pharmacies. A vulnerable group of patients received it for free in the Scientific Institute of Virology. Data collection. It was obligatory to get a signed consent form, the contact information, patient records, and the records of the doctors were entered into one single medical register red cap. All of the clinics and medical employees, so they had the laptops, mobile routers, and tablets, and the system of a unified electronic register prevents secondary testing and provides for the mechanism of follow-up. For UHAP in Tashkent, we used the express test, antiretrovirals, and electronic equipment. I'm not going to just read them.
Ключевая статья.
Here you see the key statistics for the projects, and it's the following. The UHIP project started on December 6, 2019. Within 7 months, 62,000 people were screened for hepatitis B and C. 1,810 people were screened per week. We have identified almost 2,700 people with positive for hepatitis B and 2,200 people with positive hepatitis C. This project was running between October and March. Then there was a gap due to the start of pandemic, and then in December last year it was resumed. If you look at the general incidence, it is equal to 4% for HBs antigen and 3.5% for anti-HCV. These graphs show you that hepatitis B is more prevalent among men compared to women. And same was true for hepatitis C as well. As for primarily diagnosed hepatitis B, it was prevalent in the group between 20 to 50 years, and again was more prevalent for men. And as for hepatitis C, it also prevailed in the age group of between 20 to 50 years and was more prevalent among women compared to men. If you look at the treatment cascade for patients with hepatitis B and C, as you can see here, those who were registered, they were underwent express test, but then only 86% of tests would take another blood draw. And as for patient consultation, it was given only to 57% of patients, and then only 71% from that category bought an antivirus medicine. If you look at hepatitis B cascade, out of all identified cases, 88% went through the repeat test, and 70% of them received consultation, and 86% from that category received prescription. In 2021, we launched the national screening program for chronic hepatitis in 7 regions of Uzbekistan. This year, we are planning to test 500,000 people for hepatitis B and C. At the moment, we are preparing to launch the program. And by using this opportunity, I would like to thank CDF Foundation for the support, as well as the entire medical personnel that was engaged in developing this program. Thank you very much, and I will be happy to answer all the questions. Thank you so very much for this great report. You know, I was listening to you, and I was thinking is that we have a common problem, and it is so important your endeavor, what you do, and we need to plan an event where we could exchange experience when it comes to our efforts aimed at eradicating this disease. In autumn, we are planning to hold our traditional conference dedicated to hepatitis. So far, we don't know whether this will be face-to-face or online conference, but anyway, we need to dedicate a session to dedicated to this issue. Absolutely, and I count on you arriving to Moscow. So I will get in touch with you at the end of this session. And now I give the floor to my co-chair, Elena Valerievna. Yes, I understand that the next report will be given by Mikhail Chulanov, who is the chief specialist on infectious diseases at the Ministry of Russian Federation. So he will talk about eradication of hepatitis infection, prospects, and ideas. Well, the floor is yours. Hello, Mikhail Mikhailovich, Elena Valerievna, thank you very much. We continue discussing virus hepatitis subject, and I would like to talk about prospects for eliminating hepatitis C in the Russian Federation. And I will start with the overall review and what we observe when it comes to incidence of hepatitis C. So here you see the data from the last global report for viral hepatitis, and this is the report developed in 2017, and you can see the hotbeds worldwide where the incidence is the highest. And of course, the European region is second largest in terms of the incidence of hepatitis C. So we can see 62 cases per 100,000 people are registered in our region. Indeed, that's a very high indicator. And the Russian Federation, as the largest country in the European WHO region, is ranked 6. And here we can say that the largest countries make up 80% of all patients with hepatitis C. And in Russia, we may have up to 5 million patients that may have chronical hepatitis C. And talking about elimination programs, we rely on the global strategy of healthcare segment and their efforts aimed at counteracting the disease. And we remember that the initiative was approved in 2016. And here you see the key indicators of the global strategy, and of course the most important for us are the incidence rate and the mortality rate. So the goal is to increase the incidence by 60% and the mortality by 65%. Decrease the incidence by 90%. So it is very important for us to provide sufficient coverage with medical treatment, and this is another indicator. So we believe that 80% of patients should receive treatment by 2030. So let us talk a little bit about the relevance of this problem for the Russian Federation, and contrary to usual logic, I would like to start with data on mortality rate and on the outcomes related to development of hepatitis C. If you look at this slide, by the way, again, you see the data for 2015. You will see that as of 2015, there were 35,000 lethal outcomes from fibrosis and cirrhosis of liver. Knowing the etiological structure of cirrhosis and knowing the contribution of this or the other virus in the disease development, and we knew that hepatitis C was the most contributing factor, we can do simple calculation and know that in 2015, around 15,000 people died from chronic cirrhosis caused by hepatitis C. So look at the upper graph and the curve that shows the increase in the incidence of liver cirrhosis and fibrosis, and this year we can certainly expect higher statistics because 5 years have passed in that time. If you look at the mortality rate from hepatocellular carcinoma, here we can say that around 10,000 people died from malignant tumors, and 50% account for hepatocellular carcinoma. And we also know that it is easier to do the further calculation, and we know that in 30% of cases we register hepatitis C, and if you add 15,000 to 1,500, we can say that 16,500 people in Russia die from hepatitis C. Statistics for hepatitis B somewhat better, but again, total it will be around 30 to 35,000 cases, lethal cases, what indeed is a large burden for the Russian Federation. And the next slide demonstrates you the etiological structure of chronic viral hepatitis. So what has a larger weight? The red column stands for chronic hepatitis C, and since 1999 to 2090, we see gradual increase of the share of hepatitis C when it comes to etiological structure. And talking about the incidence and the number of new cases of chronic hepatitis C that were identified in the Russian Federation. Of course, you know the statistics well, and you know that the peak fell on 2014. Then we were able to stabilize the situation and even decrease the incidence. But look at the last two bars standing for 2019 and 2021. So in 2019, we had 30 cases per 100,000 people, and in 2020, we had 17 cases per 100,000, and that is a total of 24,514. So, this jump from 31 to 17 has nothing to do with frequency of registering new cases. This is basically is the contribution of coronavirus infection that cause the problems in terms of registering the patients with chronic hepatitis. And if you look at the follow-up hospitalizations, we see the curve goes up steadily. And here we see that the figure increases from year to year. And here, so far, we cannot stabilize the situation. So here you see the mosaics of incidents in the Russian Federation. Marked in green regions are the ones where the incidence is lower, and then the brown and pink ones are the ones where incidence is higher than across Russia. But we know that the real figure depends not only on the true incidence, but also on the way the registration is organized, and a lot of regions still have to improve the situation in this regard. It is always important to understand the age structure of the incidence, and here you see the frequency of registering data on patients in different regions. And I will never get tired of saying that we should do our best to stop the peak, and we can see a better situation in the age group 20 to 30, and also for the age group 40 to 50. And we understand that with age, the chronical hepatitis C progresses much quicker, especially after the age of 40. Therefore, we can expect a large share of cirrhosis and pronounced fibrosis among patients older than 40 years of age. And we know that if the entire population has a 25% share with a pronounced fibrosis, but if you do the age-related breakdown, you will see that the share of patients with cirrhosis in the older population is much larger, and that is certainly very worrisome statistics. And again, it is something what we have to solve. As for incidence, we already have talked about it. I always provide figures from Central Institute of Epidemiology, and that is the agency that tracks antibodies to hepatitis C, and the figure has always been around 4. Of course, this is an average figure. Some populations may have a lower level, others higher. And if you look at age group between 30 to 50, the figure will be higher than 4, especially among men. There, the indicator can be almost as high as 8. We are talking about the frequency of identifying antibodies for HCV, and we understand what age and gender groups we should focus on. Talking about the incidence of genotypes, that is something what we already have talked a lot about, and over the past decade, the situation has not changed dramatically. So we can see that the dominating genotype is B, and then the second most popular is genotype 3. Its share varies between 35 to 45% in different regions. Of course, it's very important to understand the distribution of genotypes for hepatitis C, and now we have pan-genotype medicines that provide stable response regardless of genotype. Therefore, the identifying genotype from clinical standpoint becomes less and less relevant. Here you see the distribution of genotypes. Maybe third genotype share has increased a little bit, and the share of the first one went down, but it's not statistically significant. And here you see the distribution of genotypes among the age groups, and logically for the young population the share of third genotype is high, and we knew that very well. But again, it's important to take it into consideration, especially as we plan our treatment program. So we need to understand which groups need pan-genotype medicines. As for the cascade of providing treatment for hepatitis C patients worldwide, again, this is the data from Global Report from 2018. Well, I demonstrate this slide just to highlight the fact that the coverage of treatment is a large problem for the entire globe, not only for our country, but the success of certain countries is very important. And again, success rate can significantly differ. So we know that 70% of those who have to be identified are not identified yet, but out of those who were diagnosed, 70% still did not receive the proper treatment. Well, here you see the map that demonstrates the worldwide situation, and it shows how close certain countries are to reaching the goals of WHO when it comes to eliminating hepatitis C. Marked in red are those countries that are still far, far away, and unfortunately the Russian Federation is among the countries in the red segment, but there are countries that have invested significantly in the elimination programs, and you see marked in red are marked in green are Australia, Egypt, and other countries that have made a huge breakthrough over the past years and were able to decrease the incidence significantly, and also provided efficient antiviral treatment. Well, we do have these tools, and here The following slide shows you what the countries in green sector do. So Australia does not limit the access to hepatitis C treatment. France also provides access to treatment for hepatitis C within the framework of the national system of medical assurance. Georgia has done a great deal to eliminate hepatitis C and carried out very efficient screening and treatment programs. And of course, Portugal is on the way to eliminate the disease. Egypt has also enjoyed huge progress and implements efficient programs.
Лечение, тем самым значительно снижая распространенность заболевания в стране.
Cases is going down in the country because of the efficient programs.
Безинтерфероновая терапия, красная.
And so this is non-interferon therapy, IFN-free and IFN-B, so became more available and accessible over the past years. So this is our cascade of treatment for today. Different types of assessments, and for if we will focus on 4% for antibody, it's 5.7 million, and incidence half of them. And most of the patients are beyond the constant monitoring. Only around 700,000 are on under constant supervision and follow-up, and the average of 18,000 people per year in the country are getting the treatment. This number is not enough to change the situation in Russia. Several examples from the regions. In Primorsky region, it's about 500 people every year, and at that time, in the data is for 2018, mostly there was interferons used. Only 30% were getting the direct ARTs, and of course the number of people treated is not enough. And also we look at Yakutia region at the incidence and the prevalence, and blue average in Russia, red Sakha Republic, less than 50 per 100,000 of population, so it was never less than that. So the new cases. And the number of cases in 2017, so it's 501. And every year we add 500, and only 1,000 treated in in 6 years, so that's not enough. So the data from Chelyabinsk region, where the regional program has in place for a long time, and despite the presence of this program, which is good, look at this year. Every year we have 2,000 new cases, and we are treating 140 people per year. That's not enough. This is according to Tsyganova Olga. Some words about how we treat chronic hepatitis C in children, and we did that study with Mr. Labzin, and into 2020, as of September 2020, 268 medical institutions from 37 regions of Russia were questioned about the treatment, and 8.8% of children were treated, and most did not receive antiviral treatment. If we look at the age groups, so mainly from 6 to 17, so older age groups, and if we look at the medicines used in 50% of the cases, IFNs were used. Though today in Russia we have accessible schemes of ARTs for children older than 12. We could use ARTs for them. How COVID impacts on viral hepatitis C. So it has no impact on the progression of COVID, and it was demonstrated in several studies, and how the pandemic is influencing the elimination program. This is a different story. There can be negative and positive impact, and more negative, of course. So decrease of access to diagnostics and medical care provision. The regions, they have some financial limitations because of negative consequences of the pandemic. Nothing has changed in terms of safety of blood and the risk of vertical transmission, but still there can be some positive impact, which is development of lab services, increased accessibility of medicines, and improved delivery to far areas. Vladimir, sorry, just time. Yes, I'm just finishing. I will skip this slide then. I'm not going to give the details about what we have to do. We understand that. And what is important is the development of a long-term program for treatment of hepatitis. And in green, this is the profile, and in red, so these are the goals of WHO, and the green is our goals. What is the way to go? I'm confident that we will use the red curve, and Vladimir Putin half a year in his message to our senators raised the question of hepatitis C and its importance, and he said the goal to minimize incidence of hepatitis C in 10 years by 2030. For me, it is evident that we will go along the red curve. Thank you for your attention. Thank you very much. Unfortunately, we have no time for questions left. If we have some time in the end, so we will do that. Thank you so much, and that's a great pleasure to announce the presentation by Nuria. We have timing. Dear colleagues, I'm very happy to speak from this floor. I'll try to briefly speak about our experience of people living with the HIV, and my presentation I could not open it, and I will just speak. So the main documents that we use for this program, treatment of chronic hepatitis C in PLH PLWH. So this is the state program of Kyrgyzstan to fight against HIV for 2017 and until 2022. The clinical protocol still on treatment of HIV, and as of beginning of our programs, so there was the healthcare ministry order in place. The clinical protocols for HIV dated 2017. At present, it's not valid. And the new clinical guidelines are in place. Treatment of HIV and comorbidities in Kyrgyzstan Republic, and based on the decree of healthcare ministry about the ART direct drugs for people living with HIV/AIDS. There was patient selection performed to take on patients with HIV to treatment of hepatitis C. We had two goals. The first, to improve the quality of medical care, to decrease the burden of viral hepatitis in Kyrgyzstan, which is a threat to public health. It means that 90% of HIV positive will be tested for hepatitis C. 100 patients per year will be treated against hepatitis C. And the main goal, the second goal, which is elimination of hepatitis C by 2030, in line with the global strategy of WHO. And we use the electronic follow-up. So this is the electronic database. Statistics, analytical records, and medical records. So, as it was mentioned earlier, virus hepatitis C screening in PLWHO is not enough. What we do, starting from the year 2016, there is a trend towards increased number of screens among PLWH, and there is an increased incidence in our patients of hepatitis C. I will give more details and the selection criteria for PLWH. So we used them for this program. In line with the order of a healthcare ministry to pay for the patient to be included in the program, the Commission made the decision to include the patient for treatment of hepatitis C, and the Commission included doctors from AIDS services and non-governmental services, and also the informed consent was filled in. The age 18 plus, and the treatment was supposed to include patients with the viral load and with the maximum number of scores. So there were scores assigned, and comorbidities, severe comorbidities, were a limitation to start treatment, and the treatment would be started only after the condition was stabilized, and the treatment is also necessary for high risks of medical interactions should be postponed. I mean, the ART combination A5 variants, lopinavir, itanavir, so they can interact with anti-direct ARTs in treatment of chronic hepatitis C. The next patient selection criteria was the following. So ALT enzymes, fibrotic enzymes, fibrotic tests, ultrasound of liver, elastography. Co-infection of virus hepatitis B and C in PLWH and medical workers, childbearing age women, key groups of population, and it was necessary to prepare the patient. The patient was supposed to take such tests as CD4, thrombocyte count, platelet count, blood assay, non-hepatic signs of virus hepatitis C, such as arthropathy, vasculitis, and symptoms of cryoglobulinemia. Or also one of the patient selection criteria as well. To cut the incidence among the medical workers, we would prefer that as well. The patient was supposed to be follow-up, compliance should be high, and the patient was supposed to get antiretroviral therapy, and ART compliance should be high. And in order to make monitoring of efficacy of treatment for the patients, needed to take blood tests for PCR, and he need to come to visit the doctor for that purpose. And the monitoring of efficacy of ART therapy, it's standard 4 weeks, 12 weeks, 24 weeks, 36, 48, depending on liver cirrhosis. And also there was a need for control of the usage of treatment, so they check the passport and the limitation of the pills amount. So usually they are given away for 4 weeks, and then they would change the package for a new one, and the accessibility of veins for blood tests. Monitoring efficacy of treatment of viral hepatitis C was done with the treatment of during the treatment and after the treatment of hepatitis C with antiretrovirals with the direct ARTs. I will briefly explain the financing, and all of this program is financed by the state. If we look at the treatment schemes for one patient, there are 2 schemes which were used. Daclotasphere as flavovir, so it would be less than $900. For the second scheme, Sofosbuvir vilkatosphere, so it costs 2 times less, for $150. If we look at the costs of treating 501 patients with PLWH in our country with the hepatitis B. Less than $160,000 were spent on that, and per patient, per treatment course, 12 weeks length, the price was around $300. The efficacy of treatment was assessed in line with the database. It was around 80% from the patients who could take the diagnostics with PCR. Not all of the patients took the tests. And also coronavirus may be one of the reasons for that. And my conclusions, the risks during provision of services to HIV positive or with the hepatitis C under state financing includes no fibroelastography. Fortunately, the patients had elastography rarely using their own funds, and some cases when they didn't want to do monitoring of efficacy of treatment. And I think that COVID-19 had the impact here. From all of the rejections, 75% of rejections were from key groups such as, key groups, and also the doctors would introduce the data later on in the PLH group, and we don't have enough specialists for patients with severe cases, for comorbidities, and with severe comorbidities. There was a hepatitis C patient with leukemia. Unfortunately, we could not help because of absence of hepatologists, top level ones. And during COVID-19, so we have also failures in our diagnostics because the lab service was fully utilized for the diagnostics of coronavirus infections. How to solve this problem? Fortunately, we don't have the state program to fight against the burden of viral hepatitis. We need to advocate the state program to do the tests under state program to assess the incidence of viral hepatitis in Kyrgyzstan. We need to expand the financing for more activities, and the results depend on that. And we all know that hepatitis treatment is prophylaxis of cirrhosis and liver cancer. We need to perform monitoring. This is recommendation WHO, and we need to train our specialists on management of patients with hepatitis. That is it with me. Thank you for your attention.
Спасибо большое. Вы знаете, у нас
Thank you very much. We had certain changes in the program. Elena, maybe I'll just announce, because as far as I understood, Timur Khairulin, he will not speak. So this is the co-author of my presentation. I will make the presentation, if you allow me.
просьба.
but I kindly ask you to be quick, and we still have another presentation to go, and we have run out of time. I'll be short. Can you see my presentation? Yes, we can. So, dear colleagues, allow me to give you a short review dedicated to relevant issues of treating co-infections of HIV and hepatitis C. So let's start with the available guidelines that exist worldwide. So here you see the guidelines from the three leading associations, that is the EASL. The guidelines were updated in September 2020. Then the guidelines of ASASLD that renewed their recommendations in August 2020, and the recommendations, guidelines of WHO that renewed their recommendations in summer 2018. And let us focus on those guidelines that are that have seen the most recent updates. So let us look at the screening group for hepatitis C. Our American colleagues believe that the routine one-time testing for hepatitis C is recommended for all patients older than 18 years of age. The patients younger than 18 years of age should be tested for hepatitis C once time. In case of risk factors availability, prenatal testing should be done at every pregnancy. Annual testing is recommended to all consumers of injection drugs, male that practice sex with a male, those that practice non-protected sex encounters, and also to men practicing sex with a man who use pre-contact prophylaxis. Per our European colleagues' believes, screening for hepatitis C infection should be offered to all people that were tested for antibodies and were diagnosed with RNA of hepatitis C. Who and when should we treat? The goal is to decrease the overall mortality and increase the morbidity rate for liver diseases by achieving virological treatment. And our American colleagues believe that treatment should be recommended to all people with chronic or acute hepatitis C, except for patients that have short life expectancy, and it cannot be increased with transplantation of liver or other methods of treatment. European colleagues believe that treatment should be offered to everyone who have not received therapy previously and who has chronic or recently received infection. And the treatment should be started as early as possible. Acute therapy should be offered to patients with fibrosis of F2, F4, decompensated cirrhosis, clinically relevant extra liver symptoms, and the treatment is not recommended for patients with short life expectancy. Talking about genotype assessment, pan-genotype regimen therapy, including GLP and PIP, can be started without identifying genotype and subtype that will make lab diagnostics cheaper for such patients. It is also recommended to test patients for genotypes and subtypes that live in the regions where there is a high incidence of those genotypes that are hard to treat or that demonstrate certain resistance to treatment. Per American Association, genotype detection takes place in case it may impact the choice of the treatment course, and that, in other words, is an option when it comes to identifying the treatment. Cirrhosis has to be identified or eliminated, and so it is recommended to offer additional diagnosis. Examination prior to treatment should be given to all patients with hepatitis C, and it is recommended to evaluate non-invasive markers or carry out elastography, and in certain cases the biopsy of liver should take place. Testing for mutations should not be recommended to primary patients, and in the regions where the drugs that require mutation tests are used, testing should be done. Mutation testing should be done for 3 combinations: Elbasvir in combination with Grasopvir, Ledibasvir with Sabofovir, and Sabofovir with Rodapasvir. Genotype-specific approach per ESL is presented on this slide. So 2 component regimens are recommended, that is glicapavir, pifrinasvir, and sovasbuvir, vilatpasvir, and grasopavir, lasbavir are recommended only for first subtype of hepatitis C and only for 12 weeks of therapy. 8 weeks of therapy is not recommended any longer. Combinations that are recommended by our American colleagues for more prevalent genotypes in the Russian Federation are shown on this table. Talking about peculiarities of using Sovetosphere and Velatosphere, so the combination of Sovel is offered to suboptimal patients with compensated liver cirrhosis with a mutation of A93H. 8 weeks of therapy with Gazaprovir and Erbivasvir are recommended for suboptimal primary patients with F4F2. Experts recommend only 12-week course and only for 2B genotype of hepatitis C. Talking about possibilities to simplify the approach to therapy. The simplified therapy of hepatitis C should be used to increase the access to treatment when genotyping is impossible or not acceptable or limits the accept. Prior to treatment, it is sufficient to confirm the presence of hepatitis C infection and identify the presence or absence of cirrhosis. It is also needed to do the assessment of medicinal interaction, and UVO12 evaluation is not mandatory. Talking about simplifying the approach to therapy, it is recommended to offer 8-week therapy with glicapavir, pibrentasvir within 12 weeks and 12-week therapy with sofosbuvir and vilbitasphere. New simplified approach is also recommended by American colleagues. After simplified examination, the patients are prescribed with one of 2 pangenotype scheme, glypacravir, pimprinasphere, or sovasbuvir, vilpatasphere. Monitoring the case of treatment should be simplified as well. Talking about acute or recent hepatitis C, talking about timeline of 6 to 12 months, gligitavir, pibratosphere, or sofovir, vivaltosphere for 8 weeks. stable viral response at week 12, and post-contact prophylaxis is not indicated. As for the conclusions, I will not read them because they are available on the slide. And with this, I would like to finish. Thank you very much for your attention. Thank you very much. We have 2 more reports to go. I'd like to give the floor to Oganes Madayan, who will talk about state program of hepatitis C treatment during COVID-19 pandemic, challenges, achievements, and lessons learned. Thank you very much. I will be really fast, and I will focus about the importance of integrating our measures aimed against hepatitis C and COVID, and which HIV based on the examples of 2 projects. How do I change my slides? So we carry out 2 projects. One is carried out by the National Center for Infectious Diseases that I represent, another one by the National Institute of Healthcare. Over the past 10 years, Armenia has seen the increase in HIV spread. The main transmission is heterosexual, and the main risk group are heterosexual men that leave the country in search of work, and as for transgenders, their share is less than 20%. I have skipped this slide, and if you do the calculation, you'll see that every 3rd HIV positive person in Armenia does not know about their status. So we are carrying out work in order to reach 1990 goals set forth by UNAIDS. This slide tells you that the largest incidence is observed among labor migrants. So as for the structure of testing for HIV in Armenia, what is the problem? The problem is that we are not able to find those 33% that live with HIV. In our country, we carry out 140,000 tests for HIV, and 0.27% of all tested people would have a positive result. Within the framework of our project, we decided to introduce testing in the outpatient clinics, and we looked at 2 approaches. Based on one, in the city of Yerevan, we decided to improve the attractiveness of HIV test, as well as syphilis and hepatitis C. And in other regions, we provide additional financial fundings to those clinics that encourage the patients to do the HIV testing. So we saw a double increase in the number of identified cases, and that allowed us to increase the efficiency, and also allowed us to identify HIV infections at early stages, because it's well known that when the infection is identified at hospitals, the disease has already progressed significantly. So if you look at lessons learned, I would say that the testing for hepatitis is so attractive for the population that the doctors were able to persuade the population to do tests for HIV as well. And that's something that should be continued, that should continue being done. And if you use the existing infrastructure, the costs are quite efficient. So introducing this model coincided with the project dedicated to treating hepatitis C in Armenia, and I believe that my colleague Marina Konstantinovna will talk about it with more detail. All right? Okay. So we are waiting for Marina Sarkisyan, but she is the Deputy Chief for Science and the head of the Department of Epidemiological Diseases at the Institute of Epidemiology at the Ministry of Health. Hello, dear colleagues. I will try to be really fast because I understand that we are lagging behind our schedule and you might be very tired by now. So virus hepatitis are the global threat to public health, and for a long time this problem was not a focus of the society. It's a huge problem in the European region, and we believe that 14 million people suffer from chronic hepatitis form. We know that the 66th session of Regional Committee of WHO, the member states committed to eradicate virus hepatitis till 2030, and that included 5 virus hepatitis, although the focus is on hepatitis B and C as the most relevant forms, and the program is aimed at containing the number of cases, providing accessibility of testing, and providing also affordable treatment for all patients. The new era in treating chronical viral hepatitis C is marked with high efficiency of direct medicines of direct actions. It shows good tolerability and decrease in the duration of treatment. The first genotype of the disease in Armenia is observed in 92% of cases, and the frequency of viral response would be really high. In November 2018, the Republic of Armenia, with the engagement of the Center for Disease Analysis Foundation, CDA Foundation, in cooperation with the European region of WHO, local office of WHO in Armenia, carried out analysis of main results of hepatitis C and B burden. The results were included in the report about the impact of the disease on the public health of the Republic. So taking into the account the published study results, expert consensus was reached, and it was calculated that around 4% of adult education of Armenia, that is around 88,000 people, have seropositivity for viral hepatitis C. And considering the fact that viremia is observed in 70% of cases, that means that 68,000 people in Armenia have chronic hepatitis C, what is equal to 2.8%. According to data of as of 2018, the number of cases of viremia reached the peak in 2008, and it will go downward. And by 2030, we should have around 46,000 of cases. It was mathematical simulation, and we did the calibration with the use of epidemiological data, and it was calculated that if the situation maintains the same and no measures will be introduced, by 2030 the number of deaths related to liver lesions will increase by 8%. So, and we also will increase the number of new cases by 6% and decompensated cirrhosis by 8%. So here you see the curves of mathematical simulation calculation done by CDF Foundation, and here you see curves in 3 colors. So the dark curve stands for a situation if nothing would be done, and in red we see what we will have if we use a stepwise model, and green if we use the WHO. So talking about stepwise scenario, it is aimed at gradual improvement in diagnostics and treatment in line with capabilities of the healthcare system. So we should have a maximum of 3,000 patients by 2026 and subsequent period. If we adopt the WHO scenario, by 2030, we will have to have a large number of diagnostic cases, and we should have around 5,700 people undergoing treatment by 2026. So here you see what will happen if we choose stepwise scenario and what we will have if we opt for a WHO scenario. So far our country is more inclined to follow stepwise scenarios. So we were supposed to start in 2009, 65%, and that should save 660 lives. If we use the WHO scenario, then we will see that the percent of decrease of decompensated cirrhosis and the number of saved lives will be greater. All scenarios are economically effective, but the second one certainly is more efficient. Here you see the results of mathematical simulation. So if we use the WHO scenario, you see that it requires high spendings, although we see that at a later stage, economically, it's more beneficial. So taking into account the analysis results, in 2019, we received the model and results in 2019. We have developed the state program for treating hepatitis C. It was supposed to start in 2020 at the first stage. It was supposed to cover 1,000 patients, and we are talking about combinations of fosbuvir plus daglatasvir. So previous years, the collection of data would be based on emergent responses, so we didn't have exact statistics, and because we did not know an exact number of patients in Armenia, and we could only suggest how many we have based on mathematical modeling, we chose the model, and patients of first priority were patients with fibrosis of fourth or third level or extra liver symptoms, and patients with comorbidities that could have an impact on the course of the disease. So we have developed the standards for the initial evaluation of patients. So all patients are evaluated based on the single standard. We use inclusion and exclusion criteria, standards for monitoring the therapy. We also have developed a checklist for patients and created a group to control the compliance with inclusion and exclusion criteria. We also have created new standard Excel forms to collect more detailed data about patients with chronic hepatitis C, starting from data collection up to monthly distribution of medicines. Here you see the initial indicators that are required to include the patients into the program, because so far we offer this aforementioned combination. Genotyping is a must. We like to highlight that if the patient is not able to pay for elastography, the doctor calculates fee for what is still available. So a shipment of subabosphere and the glottosphere for 1,000 patients was supposed to take place in March 2020. However, due to COVID, the medicines were stuck in Delhi, and therefore the program started only in September 2020. And this is the data as of April 2021, and you see that 32% of patients are women in the age of 20 to 85 years. 22% have of patients have cirrhosis, and 35% have diabetes. 48 patients have the genotype of 3 and liver fibrosis of stage 4. So there is 24-week therapy. In the near future, we plan to include patients with low fibrosis. So we are planning to extend the program, and patients by 2021 will be included in the therapy, so we will be able to cover as many as 1,500 altogether. So in July 2020, we started program on treating HIV-positive patients with hepatitis C. So we were planning to offer treatment to 200 patients. As of today, 110 already received therapy. 17% have fibrosis of grade 4, and the success for Armenia is the fact that practically all our patients receive dolutegravir. So we are planning to switch to triple therapy with dolutegravir, and you see the majority already receive it. So you can see here that 15% are the patients with genotype 3 and the liver fibrosis of 4th stage. So despite the COVID-19 pandemic, we successfully launched the state program for treating chronic viral hepatitis C with the use of antiviral medicines of direct action, the centralized data collection, and the monitoring of medicines distribution is a positive factor. We are planning, as of 2020, to carry out the program for training programs for doctors in order to increase their testing, mathematical modeling with the help of CDF Foundation. WHO support allowed us to assess the burden and develop the program for eradicating chronical hepatitis C by 2030. Reorganizing of our infectious service helped us to unite efforts and develop a efficient program for eradicating hepatitis C. Thank you very much for your attention. Thank you. Finally, we finished our program, but unfortunately run out of time, and looks like we will have no lunch. This is the second day of international conference, and HIV is going down, while today hepatitis C has still high relevance. And in Kyrgyzia, we had 200 cases of transplantation. We have pandemic in Central Asia, and we believe that our situation impacts Russia because we have so many labor migrants coming from all countries to Russia. So let us think about what we can do collectively. You know, I will interrupt you. We will have a huge hepatitis conference in October, November this year. It will go on for several days. We kindly invite you all. Well, this problem is relevant because we could stop the problem with vaccination. You see, we talk so much about COVID vaccine, but we should also offer vaccine against hepatitis C, all right? And think of the migrants. I have been suffering from hepatitis C and D, so it's a chronical form, and I participate in many surveys here in Moscow, but they're not available in my home country. Okay, thank you very much. Why don't you come up to me in the break and we will talk to you, but we really need to wrap up this session. Thank you very much.